So I'm a cardiologist in Watford. My name's Niall. I also, for quite a long time, led virtual ward in Watford. I also chair the East of England group for virtual wards, and I sit on the national steering group for virtual wards. So I'm going to be talking about virtual wards, and as you know, the session's entitled Embedding Digital Measures Data Technology That Improves Lives. I'm just talking on my own behalf. I'm not talking on behalf of any of those bodies. I'm not sponsored to give this talk. So this is the outline of the things I'm going to talk about. I'm not going to give an introduction to what a virtual ward is. I think Andrew's going to cover that in his talk from the Cambridge experience that's following on after me. I'm going to just briefly introduce the idea. I'm going to talk about the national data. I'm going to talk about virtual wards in the UEC recovery plan. I'm going to talk about virtual wards in the 24-25 planning guidance, the NHS operational framework just published 2 weeks ago, a little bit about our local experience, and just give a few conclusions. So what is a virtual ward? This is from the document that's just come out in the planning guidance, so the national framework that's just come out. The key point really is it's a substitute, it says here, a substitute for inpatient care for patient of all ages. And the national team's been very clear to put at the bottom all the things that virtual ward isn't, that it's not OPAT, it's not remote monitoring that we were just hearing about so brilliantly described in the last talk. It is an alternative to inpatient care. It should be limited at about 2 weeks. The acuity of the patient's condition differentiates it from other community services, should be high enough to warrant consultant physician or consultant practitioner or GP oversight with clear lines of governance. For a range of acute conditions, including but not limited to respiratory problems, that's obviously a big use of virtual ward, and as you know, a lot of this work started in COVID, so COVID was the very first virtual ward. Heart failure, frailty is a huge thing in virtual wards, and then CYP, which has just come into the whole virtual ward thing to talk about children. So I would probably say that virtual wards in this country come in two groups. There's those that are led by an acute trust that focus mainly on early supported discharge and step down, and virtual wards that are based in community providers that, broadly speaking, focus on frailty. And there's a huge amount of work going on at the moment to try and get those two things to sort of work together to bridge that gap. For people who really haven't heard about virtual wards or not really sure what it is I'm talking about, these two QR codes take you to two really helpful videos, one from our team and one from another team, that give each of them is about a 3-minute introduction to virtual wards. You see patients being interviewed and things. So this is helpful summary for people who are wondering what it's all about. So there's a lot of Venn diagrams in these talks about virtual wards and what the terminology is, but they're an alternative to bedded care. There's mostly remote and mostly face-to-face. Now, mostly face-to-face is sometimes called hospital at home, and there's a whole debate about whether hospital at home or virtual ward is the best term, and there's a bit of a move from virtual ward to hospital at home. That's probably based on the idea that a lot of patients feel that something called virtual ward means they're not really being looked after closely, so hospital at home is probably the preferred term now. But it's true that patients who are in sort of frailty pathways, a lot of the care that they're receiving is delivered by caregivers in their home, whereas patients, for example, we were just hearing about in the previous thing, although she was talking about long-term condition management rather than virtual ward, that would be a sort of example of mostly remote care, patients with devices. There's a huge tech landscape for that at home being monitored. So I sometimes say that these virtual wards come in different flavors: community-based prevention of admission, acute-based early supported discharge, and turning patients around in ED. And these are the terms people use: step up and step down. But really, there's actually probably 3 rather than 2. So if we think about it like this, there's early supported discharge, patients in the acute trust who are trying to get home earlier with the assistance of virtual ward. Community-based prevention of admission, where patient sees their GP and they're deteriorating at home. GP would have called an ambulance, but they think, okay, we can onboard the patient into virtual ward. Or ED or SDEC, prevention of admission. We've got a patient in our emergency department, and normally we would have admitted them to a bed to treat their pneumonia, but we'd said, okay, we're not going to do that. We're going to send them home from our ED and look after them in a virtual ward. These are the 3 main areas that people are working on at the moment. When it works really well, they all work closely together, like this, with little bits of overlap. Everyone's working closely together. And SPOA stands for single point of access, or some people call it SPA, like SPA. single point of access, coordinating all the care between patients. So, whether someone phones their GP or they phone 111 or they self-refer, that they end up getting the same services. What people are more concerned about is where this isn't happening and it's not all working nicely together and the model looks a bit more like this. I've chosen a picture of a hospital abroad to avoid offending anybody, but this is a big hospital in Spain. But that you have a huge early supported discharge service being run by your acute trust, and there's nothing going on in the community, and there's not a lot going on in A&E. This is probably, and there's no single point of access. This is probably more of the problem nationally, to try and get people from this sort of situation to this situation. And that's not easy, because that is place-based, system-based working, where people are working together. And, as I would say from my experience, it is difficult to get people to do that. In terms of numbers, what is the national ambition? The national ambition is, I would say, probably 40 virtual ward beds per 100,000 population, so 20,000 virtual beds nationally. That is what, several years ago, NHS England set as the target. I think it was really good to set a target like that, but the slight issue that's led to is it's meant that there's two targets. There's this number, that's the capacity, and then there's the occupancy, which is set as a target of 80%. And the issue there then is that people are just chasing that number, rather than looking at other things that may, measures of impact, measures of whether this is really making a difference or not. But nevertheless, this is the target. This is the national data from NHS Digital. So the capacity at the moment has got, last year about this time it was 10,000, now it's about 12,000, so that's well over halfway there in terms of getting to 20,000, which is good. These are very, very significant numbers of patients. The amount of patients on a virtual ward today is about 9,000. 1 month ago, 9,000 patients are receiving care in a virtual ward. So again, very significant numbers. Occupancy has been really chased hard to get this up. So it was about 64% and now 74% with a target of 80%. They quote the virtual ward capacity per 100,000 sitting at about 23. There's this dip here, and that's basically because they were using a number of 51 million for the population, and then suddenly it went up to 63 million. That's not because of a whole lot of people that people had just missed. That's because the national team decided to include children as well. They wanted to include children in the national target rather than having CYP dealt with separately. I think that's quite a brave decision, because CYP virtual wards are so small that it is going to make the performance data look worse, at least until the CYP virtual wards get really big. But that's why this number dropped from 23 to 19. But overall, nevertheless, it's steady growth. Virtual wards, I'm sure many people are familiar with this document. This is the UEC 23-24 Winter Plan 10 High Impact Interventions. Virtual wards listed as number 7. But the point I would make about this is actually, if a system's working really well, all of these things, or most of these things, are related to virtual wards. SDEC, how does your SDEC link to your virtual ward? How does your frailty system work with virtual ward? How are we getting inpatient length of stay down by using our virtual ward? Community beds, care transfer hubs. UCR, how is UCR getting patients into virtual ward? Single point of access, how is single point of access getting patient into virtual ward? So acute respiratory infection hubs, can they actually pass patients into virtual ward? So virtual ward is number 7, but it's got important adjacencies to all of the 10 high impact interventions. So this is from the East of England, where I'm involved. We like to think about it like this, as a part of a jigsaw with all these other adjacent services. In the East of England, we produced this plan for how to expand virtual wards, and I would focus on the first 3 points here. Comprehensive step-up and step-down virtual ward teams present across all 6 ICBs in the East of England. If you look nationally, that is definitely not the case. Okay, there's ICBs with step-up virtual wards, there's ICBs with step-down virtual wards, but there is no ICB I can think of where they've really got step-up and step-down, or all 3 circles I showed working well and working together. That all virtual ward teams will provide the core services: frailty, respiratory, ARI, COPD, and heart failure. These are the core adult services. For people who are running virtual wards that are focused on frailty, getting respiratory and especially heart failure services up and running has proved extremely difficult, and that's because there's so often people running services in the community where they contact their local cardiology department and they say, do you want to work with us on setting up a heart failure virtual ward in the community? And they get a sort of deafening silence at the end of the phone. And then the question really is, what levers are there to make an acute trust? And the cardiologists and acute trust people like myself say, actually, no, we don't want you doing, more angiograms or whatever. We want you working with community partners to build up important capacity for heart failure virtual ward in the community. And it is quite difficult to find the right buttons to push to get that moving. So that's why we've listed this here as the core services, step up and step down in all areas. And then I've said here, as the national team said, fully aligned with UEC 111, 999, UCR, primary care, acute inpatient wards, primary care, all the adjacencies using single point of access models. We showed this to someone and they said, why don't you just add in world peace? Because, that's sort of, the idea that all of these things would actually be working together for some people just seems like impossible. But obviously, if we have the patient at the single central focus of care, that we need all these things working together for it to deliver results. And then there's other stuff here about training and funding, tech, and so forth. So this is the 24-25 operational planning guidance. As people know, I think came out later than expected. But it says here, improve access to virtual wards by ensuring utilization is consistently above 80%, with a focus on frailty, acute respiratory infection, heart failure. See, it's all the same thing over and over again in these documents. It's repeating the same message. Line with GIRFT guidelines. GIRFT are in the process of visiting all virtual wards. They're about halfway through. And I can say from having read quite a lot of the visit reports that they are extremely useful because they really do. A lot of people have expected these visits to be, pat on the back, well done, but actually they've really pointed out for people where, the gaps in their service and things they need to do, which some people I don't think were really expecting. Remote monitoring technology, rapid access to diagnostics, including point-of-care testing. This is something the national team is extremely focused on, that when a virtual ward team goes to a patient's house, that they will be able to do point-of-care bloods and not have the patient running all over the place. And that there's various devices available to do bloods in patient homes, people may know. Adjacencies to various services, linked up with SDEC and so on. So this is what it says in the planning guidance. This document's now come out, Virtual Wards Operational Framework, just the other day, and you see they talk here about whether it's called virtual ward or hospital at home because of this debate about which is the better term. This is a really good document for people who are interested. It's available online. I'm not going to go through it in enormous detail. I'm just going to show that they talk about step up and step down. They talk about where the patients are coming from. Care homes. It's really difficult to get a virtual ward service going to support care homes. They've done a great job in Airedale, but that has been a real problem. In some care homes that they point blank refuse to have patients looked after in a virtual ward in their care home. They just say if the patient's that unwell, they have to go into hospital, despite the fact the patient might be within the last 2 or 3 days of life, expected to die. I mean, I was amazed in the previous talk where she said that people think it's a marker of quality that they've got a high death rate in their nursing homes because, I think she's right, but I think most nursing homes would panic if people say, you're doing so well, you've got such a high death rate. I mean, that's not the point she was making there was about supporting people to die at home, not coming into hospital, but that's not how people would cut that data, I think. Anyway, so care homes is a really important source of patients for virtual wards and all of these other things in the way I talked about, versus step down, early supportive discharge, getting patients out earlier. Now, because the national data has been focused on capacity and occupancy, there's not a huge amount of data on impact that's been collected, and that's what this column about key outcome measures is all about. How do we know that this is really working? What is really the numbers that we can measure that will show us that we're actually having an impact on the thing that we're really trying to achieve, keeping patients out of hospital, rather than just getting the numbers up? And I'm going to come on to that. And they talk about core components, governance, 8 to 8, 7 days a week, admission criteria, personalised care, daily board rounds, hospital-level diagnostics, and so forth. Core services for the core components of the virtual ward. This is just repetition of what I was saying before. Recommendations for ICBs, because ultimately it's ICBs who have to decide to spend the money on this rather than, it comes in the UEC budget, so spend money on virtual wards rather than, expanding surge capacity in your local trust. And they talk about leadership and governance. They talk about what ICBs should be doing about referrals and flow, because, ICBs need to make sure that these SPOAs or SPAs are actually set up and running, and they're definitely not in all areas. Looking at their data across their ICB area to reduce variation, especially where one area's got a frailty service in the community, another's got acute step down, but they're not working together. Funding and workforce. So these are the ICB recommendations. But perhaps more importantly is the things that they're telling people to measure. Now, this is quite controversial because a lot of people are saying that they're really going to struggle to measure this. These are the operational metrics to make sure that you've got a good service. What are your opening hours? What's your occupancy? What's your capacity per 100,000 population? Who's in charge of this at board level? And so on and so forth. Are you getting patients in from all the things that we've talked about? But these are the outcome metrics that they want people to measure. So, for example, this is step up and this is step down. So for step up virtual wards, are you actually decompressing your local emergency department? Because, some people will say, oh, we've got 200 patients in our virtual ward. And you say, well, hang on, the A&E in your hospital is just as busy as it's ever been, so where's the evidence of impact? Are these patients that would ever have touched A&E, or have someone's just onboarded a whole bunch of other patients who would never have touched the hospital? So making sure that all the virtual ward activity is actually delivering improvement in the thing that we're most interested in. That is what this is basically saying. Step down care, making sure that it's actually helping the hospital by getting patients out of hospital earlier, and also that it's safe for patients who are being stepped down earlier by looking at things like the readmission rate, so that it's not that you're sending everyone home early, but the readmission rate is skyrocketing. And then other measures of quality. Patient acuity, are patients having a CGA? Are they having the new score measured? Are they having a clinical frailty score measured? Have their health status improved? What is the amount of activity actually going on? How many home visits are taking place? How many diagnostic tests have delivered? And so on and so forth. So these are the sorts of things that the national team is saying to people who are running virtual wards and to ICBs that they should want to know about their virtual wards. How many of your patients who've been in virtual ward are still at home 91 days after discharge? As in, are you preventing the deconditioning that we know happens in a hospital admission that doesn't happen in a virtual ward stay? What is the use of care homes and so forth? How much remote monitoring is going on? And then these things: patient experience, friends and family test indicators, patient safety, death rate. So, if there are people who are running virtual wards in the community who say things like, well, once we offboard the patient from the virtual ward, someone might say, well, how many of your patients get admitted into an acute trust in the next 30 days or 90 days? We don't know. So they're running a service to prevent admissions, but they've absolutely no idea how many of those patients are subsequently being admitted, because that doesn't come up, if they're using System 1 and the acute trust's using something else. And the national team's basically saying, if you're running a service to prevent admissions, you need to know how many of your patients subsequently are being admitted, and you need to work with BI teams to try and overcome that by using that central NHS data. Okay, I'm just going to close with a few points. This is something that people sometimes say, what is the evidence for virtual wards? There is actually quite a lot of evidence on patient experience, fewer infections, less delirium, satisfaction, deconditioning. It's really important for staff. Staff really, really appreciate working in virtual wards. There's been two big evaluations in the UK. One is showing that the amount of patients coming into A&E in East Kent really reduced with the virtual ward rollout. And secondly, that in the southeast, big analysis showing that basically for every 2 patients you onboarded into virtual ward, you prevented 1 hospital admission. Our local service, so we're in Herts and West Essex ICB, which is 3 areas basically, and this is our virtual ward is the South and West Herts HCP, which looks small on the map, but this is obviously, I think, about 600,000 people live here. It's a combined service between our acute trust and our community provider, so it's system-based. West Herts set up the first virtual ward in the country for COVID, and we onboarded about 6,500 patients to that, and then we wanted to work out how we could, what are the things that we'd learned from the pandemic. So we developed this, and at the end of 21, we launched heart failure and COPD. System-based approach. We've now had frailty, acute respiratory infection. We do some work supporting surgery, sending patients home early after surgery, and with plans to expand into diabetes. I think rather than just acute respiratory infection, we should be doing general medicine, really, supporting anybody. I think Andrew's going to talk about that, and children and young people's. And I know our data. We've had 3,500 patients, apart from the COVID ones. 70% of them were early supported discharge. It has been difficult for us to expand the prevention of admission, but we have got a lot of frailty activity, which is almost all prevention of admission. Our length of stay reduction is about a third. Our readmission rate at 30 days is 15%, which compares very well with it's the same as our inpatient stay. Although actually, interestingly, in some of our pathways, the readmission rate's lower for people we've put through virtual ward. And I didn't include the slide, but I sometimes say that it's a much I've got a picture of like two planes landing, but one sort of crashes and one lands gently, but it's a much smoother landing in the community for the patient because the care continues after they go home. Mortality rates between 2 and 3%, but of course many of those are expected deaths or in palliative care. And patient experience score, when asked to score their experience from 0 to 10, on 3,500 patients, which we've taken feedback from almost all of them, the mean score is 9.3. I mean, I'm not sure of any other NHS service I've ever come across which has got feedback at that sort of level. And I always say to people running virtual wards, if you're not collecting patient experience or proms, you really should, because it's one of your best bits of evidence. Most of the feedback looks like this. It's sort of, it's really nice, thank you. But some of it is really off the scale. Like where this says, I'm trying hard to keep to facts but not put emotion. I've never felt this amount of care and gratitude to find this little team that's made such a difference to my life. And this was to do with the fact that a doctor said to this patient, I'm sorry, you're going to have to stay in hospital and have antibiotics over the weekend. And she was a carer herself. And one of the virtual ward team people said, no, you don't need to do that. We will do this for you at home. And I think as doctors in hospital, we massively underestimate how much it means to patients to be supported at home. People think nothing of admitting a patient to hospital. They say, we'll just admit you for a few days. That doesn't sound like much to us, but to a patient it's massive. And I think we really underestimate the importance of supporting patients at home and how much it means to them. And my colleague really went there, he liaised with my oncologist, my palliative care nurse. I couldn't believe some of this when I read it. I'm now in touch with a charity that helps with wills and affordable housing. My GP oncologist did never. So because we get to know these patients very well, we're able to engage with them in a way that really is meaningful. I just show, this is our virtual hospital hub, some of my colleagues. This is our team. I think this is our CEO, who's people say funding is difficult in virtual wards. He is really, really, really focused as a trust on this project, and it's been a huge help for us because we've been very well supported. People are always interested in the technology. We use a company called Massimo, who supply this equipment for us. This is something called Radius PPG, which is a continuous saturation monitoring. This is an ECG recorder you can do at home. All of these devices are Bluetoothed, and then either we put the app on a patient's smartphone or give them a tablet, if a digital exclusion, if they don't have a device. And the tablet's got a little SIM card in, so they don't necessarily need Wi-Fi at home. People say, is this just a service of people who've got iPhones? We're like, no, we can overcome that. I think there's an important debate about the technology as well, because we use our team and we give the patient the technology. There are other people who use a model where basically they outsource all the tech to a company who deal with all the phone calls and all of this and so on. There's pros and cons, but personally I think that outsourcing NHS activity to other organisations probably is not the way we wanted to go. We wanted the patients to be able to speak to NHS staff when they've had a problem, and so we deliver that ourselves. And the same nurses go for early supported discharge who onboard the patient on the ward and explain the equipment to them, who are then the same ones they're speaking to when they go home. And we have little posters everywhere encouraging people to use our pathways. So nationally, I would say what has gone well. Virtual ward this is a spectacular national initiative. It's gone from a standing start to over 500,000 patients on board. I mean, that is massive. There are very few examples of things as big as that. The national data does show it is safe, it is highly effective. I think our cost per bed day in virtual ward is £87. It's highly acceptable and beneficial to patients. And there's a line in a lot of the NHS England documents that perhaps we don't ever really say, which is this. Where is your preferred place of receiving care? I don't remember the last time I ever saw anyone ask a patient that question, but we need to start thinking about it because it is really important. Just like we say, what's your preferred place of dying, and then trying to support people to stay in nursing homes or whatever, or their own home rather than bringing them into hospital. We do need to think also about where because as you walk around hospital ward, you often see there's thousands of patients who don't actually look that ill sitting there, but we're not really talking about where we should be giving them care. There's a significant, in terms of challenges and questions, I would say significant variation in models, definitely. there's definitely a significant variation in ambition and scale. Some people have really gone with this, and some people it's just tiny. And that's due to a variation in support. Some ICBs who've really, because virtual ward is funded from the UEC budget, so someone has to say, are we going to spend money on virtual ward, or are we just going to forget that and open up more surge capacity in our hospital? And as I hope I've made the case that spending that money on virtual ward is a very sensible decision. There is, however, a need for more data, definitely, on impact, and I think that's what these outcome metrics will hopefully help to deliver. There is a question about the role of technology, and I would say in particular in terms of frailty, where there's some very exciting new tech innovations, but like watches people can wear that tell you if they've fallen over and so forth. But it's not the same tech that we're talking about when we're talking about respiratory virtual wards and so on. It's a completely different type of tech. Light bulbs that look and see if a patient's fallen over, special mattresses that can see if someone's moving or not. There is a whole role for tech and frailty, but it's different from just a SATS probe and a blood pressure monitor. And how is that kit best deployed? Just using the kit or actually the sort of outsourced service? I think there's a real need to change existing clinical models, definitely. Willingness to do things differently, definitely. Engagement of a fatigued workforce is really important. And getting people to be willing to work together across organisations, system-based working, which is so important. And I always show this little quote, as I'm sure it's very familiar to many people, but there is a real risk that we just do the same thing over and over again rather than trying to innovate our way out of this problem, which is ultimately what we need to do. So I'll just show the QR codes for those videos again. And thank you very much for those who've helped me write this talk. I think questions are at the end, so maybe I'll just hand over to you, Andrew. Thank you very much.